Hi, and welcome to the lecture on the dementias. We are going to review a lot of information in these slides, mainly going through the different types of dementia. So follow along as you can, but definitely save these slides and refer back to them later. All right, so dementia. Dementia really isn't one specific disease, but it's a group of symptoms that affect the following cognitive functions. So think of dementia more as an overall term. So something like heart disease, it covers a wide range of medical conditions. All disorders that are grouped under the general term of dementia are caused by abnormal brain changes that trigger a decline in all of the skills that you see listed on the page. So you'll see changes in memory, attention, executive function, communication, etc. We can break dementia down into two different types. So there is primary, which is dementia that is not caused by another disease. This includes Alzheimer's, vascular or multi-infarct, and Lewy body dementia. We also have secondary, which is dementia that is resulting from another disease process. So for example, someone could have dementia related to Parkinson's disease. So we're going to start with Alzheimer's disease, and this is the most common cause of dementia. So 60 to 80% of dementia cases are caused by Alzheimer's disease. Typically, someone with Alzheimer's disease, it's going to have an insidious onset. So usually it's after the age of 65, it's progressive. It can be a slow course with some plateaus. Alzheimer's disease can run in the family, but it doesn't have to. And it can also coexist with other conditions. So something like Parkinson's disease. And I'll say this probably several times throughout this lecture, but we really need more information and more research on all of these dementias. So with Alzheimer's, there's a lot of research going into genetic testing and causes and treatment. So we will continue to hopefully learn more over time. So someone with Alzheimer's disease, we're going to see changes to communication and to behavior. So communication changes, you might see someone who has aphasia. It could present as fluent or non-fluent. Typically, their semantic system is most affected, but syntax and phonology can be affected later on. Language comprehension also declines. So a lot of times individuals with Alzheimer's disease will have difficulty with topic maintenance. They may present with echolalia, have a lack of meaningful speech, and typically in those end stages will progress to not communicating at all. Behavioral changes that we'll see with Alzheimer's disease are depression, insomnia, incontinence, delusions or hallucinations, agitation, restlessness. Many times they're disoriented, so they might not know where they are, who they are, or what time of year it is. They can feel paranoia, so have delusions of persecution, feel like people are after them or trying to harm them. And we also see a loss of initiative, so a loss of starting activities that they could normally do before. So diagnosis of Alzheimer's disease, typically brain imaging and blood work are completed, and that's done to rule out other causes. So a lot of times there'll be extensive neuropsychological testing on someone that they suspect has Alzheimer's disease, and they can also rule out other causes to lead them toward this. So truly, Alzheimer's disease can't be officially known until autopsy, but there is enough clinical evidence that shows up where a lot of times physicians and especially specialists are able to diagnose Alzheimer's disease. So typically what physicians will use is this definition that's on the slide. So that person has to have a progressive cognitive decline in 2 or more cognitive domains in the absence of a disturbance of consciousness or a medical, neurological, or psychiatric condition that could account for the cognitive decline. So once they rule out all other causes, if that person still has a progressive cognitive decline in 2 or more domains, they likely have Alzheimer's disease. So we are going to go through the different stages. So usually Alzheimer's dementia, in the mild stages, that person is going to have difficulty remembering recent events. They might misplace items like their keys or their glasses. That person might get lost in a familiar place. Maybe they're driving up to the store that they've been to many times, but they're getting lost on their way to or from. This person might also have difficulty completing complex tasks. So something like paying bills, doing their taxes. You'll also notice some mood and personality changes. It's important to know, and we'll talk about mild cognitive impairment later, but the changes that we're seeing in the mild stages of Alzheimer's dementia are not the same as normal age-related cognitive changes. So the cognitive changes that someone needs to experience to be considered mild Alzheimer's would be something that's negatively impacting their activities of daily living. So they can no longer get dressed, they can no longer run errands on their own, they can no longer volunteer, things like that. Once we get to the more moderate stages, we'll see a worsening of symptoms. So this is when some of that paranoia can start. This person might not recognize family or close friends, and they're going to start needing assistance for those activities of daily living. So things like going to the bathroom, getting dressed, and they will need prompts to initiate tasks. In the more severe stages, that person likely will lose their ability to speak. They're going to have a total dependence on others to complete those activities of daily living. Many times they stop eating, and ultimately it would end in death. All right, moving on to vascular dementia. So vascular dementia can be cortical or subcortical. So we will start with cortical vascular dementia. This is also called multi-infarct dementia. You may see it abbreviated as MID. And this is when multiple lesions or infarcts are present in both gray and white matter in the brain. So this is typically caused by multiple strokes, and it's someone without noticeable clinical signs. So perhaps they've had multiple strokes, and the strokes weren't apparent with clinical signs, but they have had multiple, which can lead to this cortical vascular dementia. So symptoms may begin suddenly, and they often progress in a stepwise fashion. So after each small stroke, you would see a fairly big decline in function. And then they'll probably kind of plateau out until the next small stroke occurs. This can sometimes co-occur with Alzheimer's disease as well. So in cortical vascular dementia, we'll see changes again to communication and behavior. So motor speech disorders are prominent in these individuals. You may hear slurred speech. This person might also have word retrieval difficulties and a hard time following instructions. We'll see things like depression and mood changes. This person will be very confused. They'll have problems with short-term memory, wandering, getting lost in familiar places, and they also may present with impaired coordination and balance. So diagnosis of cortical vascular dementia. This is, like we just talked about, it's a vascular disease that results in damage to the cortical areas of the brain due to diminished blood flow, so from those small strokes. The symptoms of this are very similar to Alzheimer's disease, so it can be pretty difficult to make a firm differential diagnosis. So moving to subcortical vascular dementia, an individual with this will, it usually occurs because of chronic untreated hypertension, and this can co-occur with cortical vascular dementia. The communication changes that we'll see, again, some motor speech changes, so difficulty with speech that looks like dysarthria, less spontaneous conversation, and possibly dysphagia. Behavioral changes could include a progressive loss of memory and other cognitive function, which again, we'll see across all of these types of dementia. Apathy, irritability, depression, again, some of those motor changes, so slowness, poor balance, an unsteady gait. This could also cause urinary incontinence that's not caused by another urological disease. So the diagnosis of subcortical vascular dementia usually can be caught on a CT or MRI, but the physicians will be looking for a thickening and narrowing of arteries that feed the subcortical areas of the brain. So next up, we have Lewy body dementia. So Lewy body dementia, this is going to look like periods of normal cognition that alternate with abnormal cognition. It's a progressive course, and it's often fairly rapid. Communication changes that we'll see with Lewy body dementia include again, more motor speech patterns, motor speech disturbances, and also hypophonia. We'll see disorganized speech in someone with Lewy body dementia. Behavioral changes, so an individual with this could have visual and auditory hallucinations. They'll have pronounced fluctuation in their alertness and attention. So they might have a period of delirium, daytime drowsiness, and then they kind of quote unquote wake up and might be a little bit more attentive or more able to participate in a conversation. So you'll see those periods of change. You'll also see some Parkinsonian motor symptoms. So this person might be very rigid while they're walking, that motor control, they're going to have a loss of that spontaneous movement. And Lewy body dementia, again, it kind of works almost like with Alzheimer's disease, where they're going to rule out other causes or other things. And you wouldn't truly be able to see, there would be a presence of Lewy bodies, but the doctors wouldn't be able to identify that until an autopsy officially. So we have two different kinds of frontotemporal lobar dementias. So you'll see this commonly abbreviated in research as FTD. The first one that we will talk about is Pick's disease. So Pick's disease is, again, an insidious onset. This usually occurs before age 65. And again, it's a progressive course, and it's often fairly slow. Someone with Pick's disease is going to have a reduced speech output, typically non-fluent. They're going to have a progressively worsening expressive vocabulary. You'll see frequent word finding deficits. This all, of course, is going to lead to a reduced spontaneous conversation. These individuals with Pick's disease might also present with echolalia and have just a meaningless repetition of phrases. Behavior changes, so you will see a wide range of changes with Pick's disease, especially changes that you would see with frontal lobe damage. So we'll see a lot of changes to executive function. You'll see personality changes, a complete disregard for social conventions. A lot of times someone with Pick's disease would have very uninhibited behavior, inappropriate social behavior. So it might be an offhanded comment or even action that they wouldn't normally do. Depression, irritability, and mood fluctuations are also fairly common. So the diagnosis of Pick's disease, a person with this would have focal cortical atrophy. You would see degeneration in the frontal and temporal lobes. So this could be something that physicians could see on a CT or an MRI. And they would have two kinds of neuronal abnormalities. So Pick bodies and Pick cells would be affected. So the other frontotemporal lobar dementia is primary progressive aphasia, which you'll commonly see as PPA. This can be caused by a variety of underlying diseases. So possibly inherent genetic pre-programming is going on. Again, like with all these other dementias, we're still looking for more research and more information. Someone with PPA is going to have a gradual loss of language function, but their memory, visual processing, personality is typically pretty well preserved until those very advanced stages. Communication changes that we'll see in someone with PPA usually starts with word finding deficits that eventually progresses to impaired syntax, sentence processing, semantics. All of those conventions will eventually be impacted. Symptoms associated with impaired speech production can also be present. So someone with PPA might also present with dysarthria or apraxia. And behavior-wise, like I just kind of mentioned, typically activities of daily living are fairly well preserved. Judgment, insight, and behavior remain relatively intact until those very advanced stages. So diagnosis of PPA, again, it's a focal dementia. You'll see that focal cortical atrophy. There will be structural and physiological abnormalities that are in the left hemisphere, which makes sense because those are the parts that are controlling language in most people. So the next type of dementia that we'll talk about is related to Parkinson's disease. So this is a sporadic gradual course. Typically the age of onset is around 60 years. A juvenile form does exist. The reported incidence of dementia in people with Parkinson's disease is pretty variable across studies. So as I said, we just need more research. Communication and behavior changes. So someone with Parkinson's disease is going to present with hypokinetic dysarthria, hypophonia. Oftentimes they'll have a rapid speech rate, a vocal tremor. They will typically present very mono pitch and have a mono loudness in conversation. Many times individuals with Parkinson's disease will start to have difficulty naming, and you'll see some of those impairments and deficits at the discourse comprehension level as well. That's when they may show up a little bit more. Another communication change you would see is micrographia. So a lot of people will report that to you. Their handwriting gets very, very small. Behavioral changes, so we'll see immobility, slow voluntary movements, facial expression is usually pretty flat. This person might have a resting tremor. They're going to have increased muscle tone and resistance to movement. We'll see disturbed gait and posture, and they'll also have the cognitive changes related to dementia will look like memory problems, confusion, hallucination, executive dysfunction. This person may also present with apathy, depression, social withdrawal, and anxiety. So someone with Parkinson's disease has reduced dopamine levels, and you will see several of the other things as well. So the degeneration of nuclei, a widened sulci, loss of selves from the substantia nigra, et cetera. They will also have the presence of Lewy bodies. Huntington's disease is the next disease that we'll talk about. So Huntington's is a gradual onset. The rate of progression and the age of onset can vary pretty widely. Communication changes that we'll see. So someone with Huntington's disease is going to have naming deficits. They'll often start using short and simple utterances. You'll notice quite a bit of grammatical errors, difficulty comprehending at the discourse level, some of those more subtle aspects. This person may present with hyperkinetic dysarthria. They will have variations in their loudness. They will be mono-pitch and oftentimes a very harsh vocal quality. In the final stages of Huntington's disease, typically that person is no longer able to communicate. Behavior, so you'll see some pretty drastic behavioral changes in Huntington's disease. So this person might excessively complain. They can be described as very eccentric, like just kind of off or bizarre behavior. Irritable, big emotional outburst, violence, and extreme confusion in the final stages is very, very common. You'll see spasmodic movement, very involuntary movement of limbs, neck, and head. So that person might be sitting there and all of those things, the limbs, neck, and head can be moving around without any control. So you want to very much make sure that that person is in a safe location, that they're in a chair that they are comfortable and secure in, because accidents can very well happen where they involuntarily move and have a fall. Other behavioral changes would be impaired memory, attention deficits, and a general slowness with any kind of intellectual activity. So Huntington's disease can be tested, it can be found with a genetic test, and it is caused by a mutation on chromosome 4. It is an inherited neurodegenerative disease. Multiple sclerosis is the next thing that we'll talk about here. So this is a chronic neurological disease that affects the central nervous system. Dementia related to MS could look like, well, with communication changes, it could look like dysarthria, so a very unclear articulation. This person might also have a hard time controlling their loudness and pitch. Problems with language comprehension and expression are usually related to cognition. This person will be frequently fatigued. They might present with visual deficits, have weakness, have pain. You'll also see that disturbance with motor skill like gait, balance, and coordination. This person could present with dizziness and vertigo, and you'll also see emotional changes. So things like anxiety, depression, and other cognitive dysfunction. So MS is damage to the myelin sheath, which is caused by inflammation that occurs when the body's own immune cells attack the nervous system. So it's typically impacting the white matter, but it can involve the gray matter in the brain. So the next thing that we'll talk about is Korsakoff syndrome. So again, this is something that we don't have a lot of firm information on yet. Korsakoff syndrome is typically due to alcohol misuse. That's what it's most often correlated with. It is also associated with some eating disorders, so like anorexia, overly stringent dieting. It can also be caused by uncontrolled vomiting, by HIV, kidney dialysis, someone with chronic infection, or someone with cancer that has spread to the whole body. Someone with Korsakoff syndrome will have impaired short-term and long-term memory. Typically, other cognitive function and the social skills do remain intact. So that person could have a pretty normal conversation with somebody, but then within a couple minutes wouldn't remember that they had that conversation. So really, we're seeing a lot of memory impairment in this group. This person could also have frequent confabulations or hallucinations. So the confabulation could include, so they're telling someone information that is not true, something that they've confabulated, but so they truly do believe that it's true. So they're not doing it to lie or be dishonest. They just believe it to be true. So diagnosis of Korsakoff syndrome, it's a clinical diagnosis by a physician. So it's typically a screening that's followed by a full cognitive assessment. So again, like with Alzheimer's and all of these other dementia causes, extensive neuropsychological testing is encouraged. There's not really a specific laboratory test or neuroimaging procedure available to identify this. Often, so someone could suffer from Wernicke encephalopathy, and that's a medical emergency. So that is something that somebody would need to get treated right away. Oftentimes, someone with Wernicke encephalopathy, once that's treated, so say they're brought to the hospital, they have, cognitive changes and impairments that take them to the hospital. Wernicke encephalopathy is diagnosed and treated. Once that clears, oftentimes the symptoms of Korsakoff syndrome will be more apparent. So they can go hand in hand, not always, but it is something that could precede Korsakoff syndrome. So the next thing that we'll talk about is mild cognitive impairment. And this is, you guessed it, something we need more research about. So someone with mild cognitive impairment is going to have subtle cognitive deficits. It sometimes occurs in the advance of dementia, but it is a significant indicator of later dementia, but not always. So someone with MCI doesn't always develop dementia, but oftentimes they do. It's kind of a transitional stage, or that's what researchers see this as sometimes, between age-related cognitive changes and dementia. So it's almost like the next step sometimes in individuals. This is different from early onset dementia. So the diagnosis, or how this is looked at for mild cognitive impairment from the DSM-5, so someone would have to have subjective complaints or concerns about cognitive changes, and it has to be corroborated by an informant. So maybe that person says that they are noticing memory impairment, or they're noticing cognitive changes themselves, and their spouse or their roommate or their loved one can also agree that those changes are occurring. There has to be impairment in one or more cognitive domain, relative to their age and educational level. Preferably, this is documented by some sort of standardized test, but as we've talked about, and as you know, there can be some barriers with that. Someone with MCI has essentially normal activities of daily living, but some of their activities might require greater effort or use of compensatory strategies. So someone with MCI could still be working, functioning, doing all of their daily things, but maybe now they had to start using a daily planner or calendar to keep track of what they're doing, or some sort of reminder app or something like that. And there has to be an absence of dementia. So the changes are very mild and there's no significant social or occupational impairment. So this kind of brings us to the next piece. And we could spend an entire week or two talking about this too. But Alzheimer's versus normal aging. What's the difference? So you can see on the left side of this table, signs of Alzheimer's and dementia. That person might have very poor judgment and decision-making. The opposite of that, someone with an age-related change that would be typical is someone that's making a bad decision once in a while. And then again, the comparison. So someone that shows signs of Alzheimer's and dementia might be completely unable to manage a budget. A typical age-related change could look like they miss one monthly payment. Alzheimer's and dementia could lose track of the date or season. Someone with a typical age-related change could forget what day it is, but then they remember it later on. So a lot of times it can be fuzzy. A lot of times, depending on the person, sometimes they might be having cognitive changes and they might get very worried about Alzheimer's, especially if they have people in their family that have suffered from Alzheimer's in the past. So it's important to get early intervention. It's important to get baseline cognitive testing pretty early on. That way you can it allows for individuals to track and see their own cognition, right? And changes that they've had, ways that it's impacting their activities of daily living. And it's important for people to understand that some changes to cognition, some changes to language, such as word finding, can be pretty typical as we get older. And it's not necessarily something to be worried about. But again, I would encourage all older adults to go and get that baseline cognitive testing to kind of track themselves if they are starting to notice those cognitive changes, and absolutely discuss it with their physician if they have one available. And I will say, actually, well, it's linked on here too, but the Alzheimer's Association website has a ton of information and they make it very, very accessible and easy to read. They also have materials that are in Spanish. So I would encourage you to check out their website because they have a lot of resources and a lot of information. The next thing that we'll talk about is Down syndrome and Alzheimer's disease. So individuals with Down syndrome are at an increased risk of developing Alzheimer's disease. So a couple stats here, approximately 30% of people with Down syndrome have Alzheimer's disease, or people who are in their 50s. I botched that. Approximately 30% of people with Down syndrome who are in their 50s have Alzheimer's disease. And approximately 50%, so half of people with Down syndrome who are in their 60s have Alzheimer's disease. That came out better. So they are, again, researching more and trying to figure out why, this occurs, and preventative measures. But symptoms that you'll see with this are some of the other symptoms that we've been talking about related to different types of dementia. So this person is going to have a reduced interest in being sociable, a decreased enthusiasm for things that they would normally be excited about, a decline in attention, sadness, fearfulness, anxiety, irritability. They might get a little bit aggressive or uncooperative. You'll also see commonly sleep disturbances, an onset of seizures in adulthood, and motor changes as well. So changes to coordination or walking. So diagnosis can be challenging. So it's hard to assess cognitive changes in someone that has an intellectual disability. Some of the key principles that are recommended is to, almost like with MCI, we really want to document a baseline adult function. So we want to by the age of 35 in the population of Down syndrome, we would want that to be documented. So what does this person do? What do they need help with? So again, you have a good baseline of what you're working with. Caregivers, loved ones can really closely watch for changes in day-to-day function. Cognitive testing is encouraged, but truly as a part of other evaluation tools. So as we know, there's not really one specific standardized test that's going to work, especially for someone with Down syndrome. So you could take parts of a standardized assessment or do one, but obviously take it into consideration with other tools. So doing a dynamic assessment would be very helpful. And oftentimes physicians want to make sure that, again, they rule out other conditions. So cognitive changes could be caused by thyroid issues, by depression, by chronic ear or sinus infections. Vision loss or sleep apnea can also cause some behavioral changes. So physicians would want to rule all of that out first. So the next thing that we'll talk about a little bit is childhood dementia. So this is fairly rare, but it does happen. So childhood dementia, there's childhood dementia and childhood Alzheimer's. It is caused by genetic disorders. So one of the most common causes would be NCL. So really there's a protein and lipid buildup that leads to cognitive decline. And there's quite a range. So symptoms can appear anytime between a few months of age and early adulthood. That's like the biggest, broadest range. Most often symptoms will show up when a child is between 4 and 10 years old. Most children, unfortunately, pass away before the age of 18. And again, you'll see some range in reporting of that number. So a child with childhood dementia they might show slurred speech, a loss of communication. Just like with the other dementias, you're going to see this progressive decline. So the parents or caregivers may see cognitive change. So that child could experience or would experience memory loss, confusion, decreased understanding, decreased new learning. You may also notice visual changes in addition to difficulty with eye contact, difficulty with tracking. So if you're having them follow a light or follow an object, they might not be able to do that. They may also present with rapid blinking. This population may also experience dysphagia, a loss of motor function, so decreased muscle tone and control, decreased balance. And there are some links on the bottom of this slide for other resources where you can find out more about childhood dementia. So diagnosis, like with all the others, the other types of dementia, it can be pretty challenging. This condition is rare, so we don't know a lot about it. The differential diagnosis is pretty key. So oftentimes these children, parents or caregivers are noticing changes. Teachers are, someone's noticing a cognitive change or decline. So they are starting to do testing, but oftentimes these children are misdiagnosed. So they might be labeled with a learning disability, somewhere like an autism spectrum disorder, a developmental disorder, and then it's, once they kind of get to know that child better, once they maybe try treatment options and it's continuing to progress, they might realize that that initial diagnosis was wrong. So oftentimes they go for more testing or happen to find a specialist, which would be best case. A specialist in this area is not very common, as you can imagine, but then at that point they are able to diagnose it as childhood dementia. But again, it can be pretty challenging to get there. Genetic testing is available, but again, it's just the accessibility of that can be pretty hard and rare. So that takes us to the end. I do have a list of references and resources. All of the information, well, most of the information from those types of dementia comes from that ASHA practice portal. So I would absolutely bookmark that site. They make it really easy to compare different types of dementia side by side. We don't necessarily, as an SLP, you are treating the symptoms, right? So it might not necessarily matter in each of your treatment sessions what type of dementia that person has, but ultimately it does, because you want to understand the overall prognosis. You want to understand what that course could look like, if it's going to be a rapid or slow progression of skill or decline of skills. And it can also help in education and training with family and caregivers. So we will talk a little bit more in class, but thank you for joining me for this lecture, and I will see you later.